Welcome back, everyone. Good morning, Press Ginsburg. I'd like to welcome Press Ginsburg this morning. As before, I ask that you submit your questions in the text box to the panelist, and we'll ask those questions at the conclusion of his presentation. I'll turn it over to you, Professor. Thank you.
Thank you. I'm really pleased to be here and not having to fly up on a plane and then stay in a hotel to do this. One of the few advantages of the pandemic. See, is my screen sharing now?
It is.
Oh, good. Anything else I have to do? I have to put on slideshow. Okay, I think I'm set now. At least I hope so. Actually, how do I see the slides? Sorry for the not being familiar with the software. I could just see my face.
Professor Ginsburg, you may be able to hit the third button under the microphone. It should be a microphone, a camera, and then the full screen mode.
Oh, I see. No, it didn't. Oh, I see. Did that do it? Oh, it shows screen.
That took your presentation down. It's back up for us to see, Professor.
Yeah. Problem is, I need to see it. So.
Professor, can you select the slideshow on your computer so that you can see it on your computer?
I can see a stop. Oh, wait, change presenter. Is that? No, that doesn't do it. People can see my screen.
Professor Ginsburg, since we can see you due to the camera, maybe just look at your slides and advance forward. I don't think that'll turn off your camera.
Okay. Okay, is this okay?
Looks good, thank you.
Okay, sorry about that. I'm going to talk about how we can move forward on alternative payment models. And, you know, the ground rules is that I'll be presenting my own views, and I'm not speaking on behalf of the Medicare Payment Review Commission, which I serve as vice chair. Vice chairs have the privilege of speaking for themselves and not for the commission. I don't have all the answers, and I'm going to present what I think in order to stimulate your thinking. I'm very eager to get your ideas and feedback. So when it comes to questions, you know, comments are good as well as questions. Okay, there's long been enthusiasm for alternative payments models, and this, as far as I can tell, is continuing. That really going back at least a decade, my sense is that provider leaders insurer leaders and policymakers have been quite enthusiastic. And in fact, the support from the policymakers has been nonpartisan. I use that term rather than bipartisan. It's not that each party agreed it was in favor of this. It's just that many policymakers on their own decided they were in favor of it. So that's why I call it nonpartisan. We've seen growing enrollments in Medicare, in commercial insurance, and in Medicaid. And the Medicare models continue to proliferate. And indeed, the Medicare models from the Medicare Innovation Center survived a skeptical HHS secretary. If you remember at the beginning of the Trump administration, first Secretary of HHS was Tom Price. Who was a physician and quite skeptical and really kind of derailed the Medicare program's movement on this. But fortunately, he didn't last that long. And his successor, the current secretary, Alex Azar, has been quite enthusiastic from the beginning, as has been the rest of the administration. And the enthusiasm, but the penetration so far has not been that high. Many of the contracts involve very little provider risk. Many of them, at least in Medicare, are upside only. And savings have been achieved in some models, but often not to the payer after the savings are shared with providers. And really a much smaller degree of savings than what is needed to keep healthcare affordable. So what's needed for alternative payment models to realize their potential? I think one thing we need to do is to transition Medicare policies from a huge demonstration enterprise to core payment approaches. And we need to shift from attracting provider volunteers and use a mixture of mandatory approaches and penalties for not participating. And we need to revise the models to engage enrollees. Now, it's not clear to me how to expand commercial insurer activity. Perhaps higher Medicare and Medicaid participation will help, but you may know a lot more than I do about this. And we need to make some key design choices. First, whether to emphasize population-based models such as ACOs or primary care models, or to emphasize episode models. And we're going to need to resolve issues in crediting savings across the models. When an enrollee is covered by an episode model and an ACO, who gets the savings? I also believe there's the potential to broaden episode models to include those not built around a major procedure. So where are we now? There was a study in the Health Affairs blog that appeared late last year, that appears every year by a group at Duke University, saying that 44 million people are covered by ACO contracts. And that sounds good. And interestingly, they said more lives are in commercial ACOs than in Medicare ACOs. But when you do some calculations, you see that Medicare has much higher penetration. But in any case, the 44 million is quite small in relation to our national population of 331 million and our number of people with insurance that's somewhat over 300 million. And it's much harder to quantify those covered by models other than ACOs and the overlaps in the models. I remember interviewing hospital CEOs, and one in particular described it as there's a dock and canoe problem. What he said is, when you have 1 foot on the dock and 1 foot on the canoe, you're not in a good position. And that's the way many providers feel, that they have their contracts paying that some of their patients are in population-based contracts, others are in pure fee-for-service. The more they invest in increasing their efficiency on a population basis, the more they risk losing on their fee-for-service patients. Now, the record on savings. Blue Cross Blue Shield of Massachusetts, your neighbor, achieved substantial success with its alternative quality model, which actually began before Medicare ACOs, but there have been very few formal evaluations of other commercial insurance activity. Some of the Medicare models have improved quality, appears as though none have decreased it, and some of the models have reduced spending overall, but shared savings has often prevented program savings in many cases. And the estimates of overall savings are in the 1% to 2% range, and that's not very high. I believe that we need stronger incentives to participate, for providers to participate. And the voluntary approaches that Medicare has used and commercial insurers have to use have shortcomings. One is to get volunteers, you need to keep the downside risk very small if it exists at all. You need to keep the benchmarks high. And there are difficulties in evaluating the experience. There is documented extensive provider self-selection. Why shouldn't they? If your benchmark is based on your historical experience, well, this is much more attractive to providers with high costs. And maybe that's not the worst thing in the world, but it'd be good to get the other providers involved as well. And a question I want to pose to you, a rhetorical question, is we've been experimenting for well over 10 years and on a heavy-duty basis in the Medicare program since the Innovation Center began almost 10 years ago, maybe 10 years ago. And maybe instead of continuing to experiment like crazy, we should be adopting approaches that have worked and experiment mostly to expand the reach of our model, such as various chronic disease episode, and then make changes over time based on experience. Past federal policymaking has involved much less experimentation. I was around actually at the Congressional Budget Office when the Congress enacted the Inpatient Prospective Payment Program for Medicare. This was never a Medicare demonstration. People pointed to the experience of New Jersey, because New Jersey, which had all-payer rate setting at the time, decided it wanted to use DRG payments, prospective payments, and it went to Medicare asking if Medicare payments could follow the same DRG approach, and it was granted a waiver to do that. But anyway, within a few months, all hospitals in the country were participating as a permanent program in inpatient prospective payments. Program that has been so successful in my perspective that it's been imitated throughout the world. It's probably the main US export in health policy has been DRG payments. We enacted the physician fee schedule, which took effect in 1992. Again, we never did a demonstration. How about paying the physicians differently? Let's see if we can get some volunteers. We just enacted the law, had a phase-in, and put it into effect. These policies were revised on the basis of experience. So what's different today? I mean, another question is, have policymakers just lost their nerve to do bold things in healthcare at least? Or maybe we have a phenomenon where the stakeholder opposition The degree to which stakeholders have armed themselves with lobbyists and campaign contribution chests have just made policymaking more difficult when stakeholders are affected. So I want to talk about whether to use a mandate or stronger incentives. And mandates have been used in some demonstrations, and I think very effectively. So some demonstrations, like Medicare has one in joint replacements, included all providers in selected geographic areas. And this was a very strong design for a demonstration, because there was no opportunities for providers to select whether to go in or not. And the experience in the affected geographic areas could be compared to the others. And I think there are some important practical barriers to mandates. For example, think of the ACO. Presumably, some physicians will not be chosen to be members of an ACO. And there's always the issue of those physicians. Does that mean you're kicked out of the Medicare program, that you can't bill? So that would be a reason for making it an incentive program rather than a mandate, but with strong incentives. And then the burden on very small providers. So the incentive approach would be you lower the fee-for-service payment rates for the non-participating physicians, and perhaps even increase the differential over time. I think that's a practical way to really boost provider participation and also really increase the chance of this approach succeeding. Now, the issue of strategic emphasis about model types. We have the population models. The ACO model is really talking about a population of beneficiaries attributed to a particular ACO. And we have the primary care models, which use some form of partial capitation. We have episode models for both acute major procedures and for specific chronic diseases. And I mentioned before the accounting issues really have not been cleared up that well. Basically, a beneficiary has a hip replacement. There's an episode payment to a group of providers for it. But what about the ACO? Does the ACO just get the cost of what might be a higher additional hip replacement? Or does the ACO get an opportunity to benefit from having steered the beneficiary to an efficient provider to do the hip replacement? I would say one option is emphasizing the combination of primary care and episode models. So the primary care model would include total cost incentives, some incentives for the primary care physician based on the total cost of beneficiaries attributed to them. But many of these models are really not well developed at this point. The alternative would be an option of building around ACO models. So you would have ACOs actually playing a role in the payment of physicians, of their physicians that have joined the ACO. So in a sense, the ACO might have a bundled payment to physicians for an episode. And this way you wouldn't have any issue of who to credit the savings for. And in a sense, both would get the appropriate credit, both those involved in the episode and the ACO really getting the credit for the right number of episodes and steering to the more efficient providers. I think big opportunity and demonstrations for the future is episode models for chronic conditions. And these models avoid the concern that episode payment generates more episodes. And the CMS Innovation Center is doing a lot here. They have ongoing oncology model, a kidney disease model. And to me, the key is choosing an episode for which the adjustments, the risk adjustments can be effective. So I would think the kidney disease is probably a good one because there are a lot of measures of the stage of kidney disease, and there's a need to avoid diseases with important comorbidities, such as congestive heart failure, which I think would be a poor candidate. Next issue is beneficiary engagement. And unfortunately, the Medicare ACO has had a history of limiting beneficiary engagement. I think when the Congress enacted the Medicare Shared Savings Program, which was a non-controversial part of the Affordable Care Act, I think Congress was afraid of beneficiaries being angry at this new approach to payment it was launching. So pretty much cut the beneficiaries out of this. And I think the beneficiaries not being involved really limits what alternative payments can accomplish. Some models are now allowing ACOs to offer incentives for primary care, such as waiving the deductible for primary care for patients. Here are some potential approaches. You could ask the beneficiaries to identify their primary care provider. And at minimum, this will give you more accurate attribution than the current retrospective or prospective approaches that are in use. What I would like to see is Medicare incentives for beneficiaries to choose an ACO and to favor the ACO providers. This actually is what I've seen in commercial coverage, at least in California, where I've done a lot of interviewing in the past, that enrollees in those plans have additional cost sharing incentives to use an ACO provider, provider with an ACO contract with that insurer, as opposed to other providers in the insurer's network. But in Medicare, the extensive Medigap coverage really undermines so many potential incentive approaches. And I think the answer to that is to revamp Medigap policies in order to favor the ACO providers. And there's an experiment going on, again, with Blue Cross Blue Shield in Massachusetts, where they are selling a Medigap product that actually has these incentives so that the enrollees do better when they use the ACO providers. Few comments given where we are in, well, what about COVID-19 and how does that affect alternative payments? Well, it does really have a number of effects, some of them uncertain. There's some key operational issues being faced now. And the way I would describe it is that there's a need to protect providers and payers from pandemic-driven volume changes in determining rewards and penalties. So what I would do is suspend penalties and rewards for 2020. Because if you go from, say, hospital to hospital or just from area to area, you have some that because of the burden of COVID-19, they have very high volume. Those hospitals are very busy, but in many other areas, the hospitals are not, they have lower volume than usual. So in a sense, whether volume is up or down from the base year of 2019 depends much more on what's going on with the pandemic in that particular area than what the hospital is doing to increase efficiency in delivery. So in a sense, I don't see any choice but to just suspend these incentives for 2020 and unfortunately, maybe even 2021, since we know that the pandemic will still be going on, at least for the first 6 months. Next question is, will the pandemic increase or decrease provider interest in alternative payments? And really it could go two ways. Many providers are in more precarious financial positions than they typically are, and that might make them more resistant to taking on risk under an alternative payment program. On the other hand, some providers that had a fair amount of capitation, these are mostly physician practices, are feeling very good about it because they've done much better. It really provided financial security to them from this drop in volume that had nothing to do with their delivery. I think that alternative payment is going to be important in sustaining some of the new delivery approaches that are evolving in response to the pandemic. You know, think of virtual visits, you know, telehealth, video visits. You know, there's been we've probably learned 5 or 10 years as much about using them in months under the pandemic because of Medicare and many commercial insurers all of a sudden paying for visits from the patient's home over lines like we're dealing with. And I think there's a major potential in these visits to improve efficiency and improve the patient experience. But under fee-for-service payments, there are major risks of fraud and abuse. I'm really worried about what's going to happen in Medicare if they continue their current policy with paying the same rates for visits as in-person visits, and with, I think, no cost sharing for the patients. And it just seems to me a golden opportunity for people who want to defraud the program to fabricate video visits. Also, there was an interesting article in JAMA by Bob Berenson pointing out some of the practical things that if a video visit was paid at a rate that's suitably, you know, less than an in-person visit because the resources are less, just the fixed costs of billing might actually make it so that it's not worth billing to the physician practices. So, you know, in a sense, a real reason to move to models that are paying at least on a partially capitated basis, so that it just becomes natural about how extensively do you want to use virtual visits and other tools of telehealth. And we have the similar issues for patient-provider messaging. I have the good fortune that the internal medicine practice I was in joined up with I switched to a hospital that it's affiliated with data system, and that I can freely send and receive brief messages from my provider. Now, these shouldn't be paid as e-visits. They're often just a simple question or two, but it really has made a difference in the seamlessness and the patient experience of care. I think that's all I have, and I'd be delighted to hear your comments and answer your questions.
Thank you, Professor Ginsburg. This is Don Gorman again. I do have a couple of questions that were raised. I think I'd like to start with this first one. How do we convince providers that APMs don't just mean paying providers less?
Well, I think the provider has to see a clear opportunity that if they're going to change their delivery, that they can make more money. So in a sense, yes, ultimately, fewer dollars will come in, but if the provider's costs are lower, then they'll do well. And I'm glad you raised the question, because I remember encountering this. I've done a lot of interviews in my work, that it's a problem if the provider has excess capacity. It'll be hard to see how they could benefit from alternative payments. If the provider is busy, they can very well benefit. And I remember interviewing a hospital CEO who explained that they're very interested in it because the area they're in is growing, and they don't want to have to build another tower. They don't have the access to capital that would do it. So alternative payment was relieving them of a future problem. But in a sense, I think that you really have your finger on it. This is a problem in getting volunteers. It may not be attractive to every provider, even though I think from the system perspective, from the payer's perspective, and I'm including the public payers and thus the taxpayers as well, who are behind the public payers. I think this is something, there'll be some pain, but the healthcare system has to become more efficient and more affordable.
Thank you for that. Second one is about price transparency. Could price transparency encourage APMs?
I don't think, no. First of all, I should say I've been very skeptical about the virtues of price transparency for a long time, because we're often dealing with prices that don't mean anything to patients. But I would say that, APMs probably will make prices less transparent, because it's not going to be that clear what the provider is going to be paid until the end of the year, when the shared savings or shared losses are rectified. So I think this might be a direction opposite transparency. Ironically, while you ask about transparency, let me take a couple of minutes to say that there's long been concerns about giving patients information they can't do anything with constructively. But the research literature is developing in health policy research, showing that many potentially ideal situations for price transparency, enrollees with high deductible plans, things that are simple like getting an MRI for the lower back, that even though a rational consumer would make a lot of use of the price transparency, and also the other thing is that many insurers are giving their enrollees all the price information they need, which is very different from publication of prices. But yet the response to that by patients hasn't been important. I keep thinking of things in price transparency question. My familiarity with Tyler Brannon and the New Hampshire Department of Insurance comes from having done a qualitative study of the New Hampshire experience with price transparency on a statewide basis. And my recollection of the study was that the biggest positive impacts were through educating the policymakers and the employers about the variation in prices across providers. And I think this happens over and over again, that there's a real benefit from educating the policymakers and the employers, but as far as actual patients making decisions, you never see much of an impact.
Thank you. Another question that came in is, well, there's two here that are kind of related. What component of healthcare financing in another country might be most insightful for encouraging APMs in the United States?
That's a good question. I think most other countries have used a very distinct approach. They have continued to use fee-for-service and put various constraints on it, like constraining the resources going into healthcare, such as how many facilities are built. Sometimes with physician payment, they just say, well, there's a certain budget for physician payment. If you use it up, you don't get paid until the next quarter. I think I don't know as much about it, but I think that the Netherlands would be a place to look, which has competing health plans and does have approaches involving capitation. I think that would be rich to look into their experience.
Thank you for that. Next question is, well, this question, what are some ideas about how to encourage participation in alternative payment method models for smaller providers who might not have the infrastructure to enter these types of arrangements? And there's another question that's sort of related to, is like, how significant are existing systems of claims processing and health benefit administration? How do you see those as perhaps roadblocks to APMs?
Oh, sure. Well, for the small providers, clearly the small providers need help. And in some areas, actually California in particular, but Massachusetts somewhat, it's very common to have independent practice associations that small physician practices join, where the independent practice association contracts with the insurers on some type of alternative payment model and negotiates the rates and really supports the small practices in upping their data systems and being able to practice in the system. There are, startup companies that seem to be successful. Elidate is one, which in a sense have, formed a business of, supporting small practices that want to participate in ACOs. So I think there are approaches there. But of course, the alternative payment models need to be attentive to the challenges that small practices have. And the one thing you don't want is for it to be so difficult for small practices that you actually encourage further consolidation, having them just give up and selling to a hospital system or joining a larger group. Oh, the second question you asked was about the claims processing system. I think an important element of alternative payments, particularly ACOs, is that the insurer needs to be providing data to the provider, because the provider just knows what's happening inside their walls. They don't know about patients that might be attributed to them, that might be going to an emergency room elsewhere, and they don't know about what prescription drugs the patients are actually taking. Both the compliance with the drugs that they're prescribing and drugs that someone else might be prescribing. So, of course, insurers have the claims data for prescriptions, which is actually particularly useful for determining early, what's going on with the patients, what's their problem. So, insurers have a very important role to play in supporting the providers that they're working with data, with timely data.
Great, thank you for that. Your answer to the first part of the question touched on another participant's question about consolidation. And this participant was requesting whether or not there have been any studies that you know of about how hospital consolidation with physician groups could perhaps blunt APM incentives in favor of keeping care in the system.
Oh, yes. I think, one of the problems with hospital ownership of physician groups is that the physicians, lose their freedom to refer patients to the specialists that they feel would be the best for them, either on a quality basis or an efficiency basis. So I think that really interferes with making care more efficient.
Okay, the next question that came in, I'm just going to read it. What success have states had in encouraging APM models on the commercial side? It seems to take trust, transparency, and cooperation between providers, health systems, and payers to allow for important progress. What can motivate a system to move towards payment reform in a meaningful way?
Yeah, that's a great question, and I'm not sure what states can do. I know that in Maryland, the Blue Cross Blue Shield plan called Fair Care First, has been in a alternative payment arrangements with primary care physicians for a few years, where they have incentives. I think it's upside only incentives to for their overall global efficiency. And they give the primary care physicians data on the efficiency and quality of the different specialists in their network. And I guess, so it's not the state of Maryland, but the major Blue Cross Blue Shield plan in Maryland has really been pushing this forward. It's an interesting question that I don't know the answer to, as to whether we see more alternative payment activity in the Blue Cross Blue Shield plans, which in many markets are, the largest dominant insurer, or in the national plans, the Uniteds, the Aetnas, the Cignas, which in a sense may have more resources to develop these plans, but don't have the market penetration, at least in many areas, that some of the Blue Cross Blue Shield plans are. So I'm not sure where more of the innovation is happening.
Okay, thank you. I think there's one more which may or may not be addressable by you, Professor Ginsburg. Maybe it could be left for the next portion about comments. New Hampshire does very little to share information about value-based care and payments across payers and models of integrated care in New Hampshire. The information in the rate review hearing is shown in one slide as an aggregated assumption about risk contracting. Consumers and employers would benefit from knowing what type of payment models exist across New Hampshire. What are the outcomes? How are they improving efficiency and patient experience?
That's a good question. I think for the employers, I think the more than half of our group coverage, nationwide at least, is where the insurer is not taking risk, but is really serving as the administrator for the employer. And I think one of the barriers to moving alternative payment forward has been that, under typical ASO contracts, the insurer needs to get each employer's permission to participate in a model. So to the degree that employers were more knowledgeable about the alternative payments and its potential, that might actually make that go easier. It may actually remove somewhat of an impediment to commercial insurers' involvement. I'm not sure at this point whether the consumers, the beneficiaries, the enrollees, what information they should have. To me, the ideal is to know that, and it's kind of to know that their primary care provider is in, say, an ACO, and their primary care provider and his or her colleagues at the ACO have an incentive to deliver care efficiently. And it probably would be a good idea, to actually, stay within the ACO network, unless you have a problem with some of that. One context thing, and this is at least in the Medicare program, is that federal policymakers see ACOs and other alternative payments as a way to get the Medicare beneficiaries who have not opted to join Medicare Advantage plans into some system which actually is not completely, unconstrained fee for service, to get them into a system where providers have incentives So in a sense, it's like a halfway approach to managing care. And I think that of course, with commercial insurance, you have the HMO enrollees, not anywhere as numerous as the Medicare, as percentage as the Medicare Advantage enrollees, but in a sense, it's a way of getting somewhat more management into their non-HMO components.
Thank you. I think this might be the last question. How do we change a standard of care that was created in a fee-for-service system?
Ooh, that's a good question. I think that question to me just demonstrates how challenging this is. And that I think is going to be a major constraint. Hopefully we won't just give up and say, hey, there's a fee-for-service standard of care out there and we can't do anything about it. But I suspect that there are many opportunities with alternative payments or with provider organizations involved in it to accomplish a lot without challenging the standard of care. So in a sense, there are far more coordinated and efficient ways of delivering that standard of care. So the more I think of that question, which is really an intriguing question, is, I suspect that the proponents of alternative payments are not envisioning a new standard of care, but seeing substantial opportunities to improve things within the existing standard of care. It was set. So in a sense, a standard of care, there are quality aspects to it, but there also may be, and this is not part of the standard, kind of an inefficiency to it, just going about it in a way that's often not attuned to patients, not attuned to waste and duplication. I think that's where the big opportunities are. Yeah, actually changing a standard would be the toughest thing.
Thank you. I think this will be the last question. It just came in. What is in place to prevent capitated models leading to an incentive to providers to not provide necessary care or refer when needed to specialists, i.e. the 1990s gatekeeper model?
Sure. I think this is the quandary we've faced, throughout all the decades that I've been in healthcare, that we have capitated models with an incentive to underserve, and we have fee-for-service models with an incentive to overserve. And we're trying to somehow get between those things. I think quality monitoring and quality information is a key thing, I think, in dealing with the capitated models incentive to underserve. But I think where we're really going is trying to blend the models. So in a sense, we're not talking about necessarily fully capitated models. It's always partially capitated models. And the partially capitated models, let's say with primary care, and also the shared savings approach rather than a full risk approach, is attuned to the fact that maybe we don't want those incentives to be too strong. And by the way, a lot of things that happen to patients are not under the control of, say, a primary care physician. Primary care physician can steer the patient to a high quality, efficient specialist. But there's this uncertainty about, well, still they have no control over what happens to the patients once they've been referred. So yeah, I think the ultimate goal here is to somehow blend the fee-for-service and the capitated, let's call it, but now we use the term population-based incentive to avoid the worst of both of each of them, and to try to get to the right place.
All right, well, I thank you for that response as well. And I believe we've gone through all the questions, so I will turn it back over to the NHID and the commissioner.
Want to thank you, Professor Ginsburg, for your informative and thought-provoking presentation. We now shift to our public comment period. So we'll accept public comment. Please either raise your hand in the software or hit *6 to be recognized. When you speak, we ask that you identify yourself and the organization you represent. I'm not seeing any hands raised. We'll give it another minute or so, and I'll check with Ariane Sibley from our office to ensure that I'm looking in the right spot for raised hands.
Seeing no raised hands or comments yet at this time.
Thank you, Ariane. Well, seeing that there are no comments, no raised hands, I want to thank Jen and Don for helping me through this presentation, along with all the staff here at NHID. We've already thanked Professor Ginsburg, and I think he signed off, but thank you as well. I'll see some of you this afternoon at the commission meeting, and if you have any questions or comments, you can contact the department at email below. And our report will be, this presentation will be available next week. And our full report will be available in December. Thank you all for your time.
Oh, Commissioner, I have one question.
Oh,
Okay, I'm sorry. This person is going to submit comments instead.
perfect.
I'm still seeing no raised hands and no comments. So yes, I think we're okay to close.